begin, lower the patient's gown to his waist and inspect his chest. Note its symmetry and observe the costal angle, angle of the ribs, intercostal spaces, and muscles of respiration. When comparing the back, sides, and front, see if the antero-posterior, or AP diameter, is about half the size of the transverse diameter, as it normally is in adults. For an older adult, however, the AP diameter is likely to be more than half the size of the transverse diameter. Now inspect the patient's skin to detect signs of respiratory or other disorders, such as cyanosis, pallor, superficial venous patterns, and overly prominent ribs. Also use this opportunity to locate thoracic landmarks and visualize underlying structures. This will help pinpoint your findings later in the examination. Do the same for the patient's lateral thorax and posterior thorax.
I'm going to take your pulse now, and you can just relax and breathe normally.
While palpating the patient's pulse, determine his respiratory rate, which usually is 12 to 20 breaths per minute. In a child, the respiratory rate normally is much faster, ranging from 20 to 40 breaths per minute for an infant, to 16 to 20 breaths per minute for a 10-year-old. By age 17, the rate usually is the same as an adult's.
I'm going to shine this light on your chest so I can monitor your respiration.
Also, note the patient's respiratory pattern and chest movement. He should breathe easily and evenly, and his chest should expand symmetrically, with no bulges or accessory muscle uses. Next, listen for respiratory sounds while observing his face. You should hear no stridor or wheezes, and see no nasal flaring, lip pursing, or cyanosis.
I'd like you to put your mouth pads together like this for me, please.
To complete inspection, check the patient's fingers with the Shamrock technique. The fingers should be normal. If you see clubbing, suspect a cardiopulmonary disorder.
I'm going to be palpating the muscles in
After warming your hands, begin palpating the muscles and bones of the thorax, which should be symmetrical. There should not be any pulsations, tenderness, bulges, depressions, masses, or sensations, such as crepitus or rubs. Also, palpate for thoracic expansion. With your thumbs at the level of the 10th rib, watch your thumbs diverge during respiration. Usually they move in and out symmetrically with each breath.
Now I'm going to do the same thing to your chest, so please keep breathing normally.
Place your thumbs along the costal margin and xiphoid process, and watch them diverge as the patient breathes. They should move equally. Now assess for tactile or vocal fremitus by palpating symmetrically as the patient repeats a few numbers or words.
Please repeat the number 99 slowly.
99, 99.
Using a light, even touch, compare the fremitus on both sides with your palms, or the ulnar aspect of your hands.
99, 99.
That's great. Now I'm going to do
And repeat this assessment on the anterior thorax. Expect to feel the most fremitus on both sides of the sternum over the second intercostal space, where the bronchi bifurcate.
99, 99.
To palpate the trachea, place both thumbs, or your index finger and thumb, in the suprasternal notch. Then slide them gently up and out to the side. The trachea should be midline above the suprasternal notch. Now percuss the thorax systematically and compare each side bilaterally. Plan to percuss in a sequence, such as this one for the posterior thorax, both sides of the lateral thorax, and the anterior thorax.
I need you to cross your arms, across your chest, and bend your head forward for me, please.
For the posterior thorax, this position exposes the lungs better.
Now can I have you raise your arms above your head?
For the lateral and anterior thorax, this position offers better lung exposure. In all locations, note the intensity, pitch, duration, and quality of percussion tones. You should hear dullness over the ribs, heart, and diaphragm, and resonance over the lung fields. Because young children usually have thinner chests, they typically have hyperresonant percussion tones. Similarly, older patients may display hyperresonance because of increased lung distensibility.
Tapping on your back again. Actually, this time I'm going to be putting pieces of
Now use percussion to measure the patient's diaphragmatic excursion by following these steps.
Take a deep breath and hold it for me, please.
Percuss down the scapular line to the lower border, where resonance changes to dullness. Mark that point with a piece of tape or pencil.
Good. You can breathe now, and when you're ready, we'll do it again.
I'm ready.
Take a couple of deep breaths. Exhale as much as you can and hold.
Percuss up from the first point, and mark where the tone changes from dullness to resonance.
You can breathe normally now, and when you're ready, we'll do the whole thing on the other side. Take a deep breath and hold, please. Exhale and hold.
The distance between the tape marks, or diaphragmatic excursion, should be 3 to 6 centimeters on each side, and the diaphragm should be slightly higher on the right because it sits over the right lobe of the liver. Next, auscultate the lungs, comparing sounds from side to side to assess the condition of the respiratory tract.
Arms from under and bend your head down. I'd like you to take some deep breaths through your mouth. That's good. Now breathe at a pace that's comfortable for you.
Using the diaphragm of the stethoscope, plan to auscultate in the same sequence you used for percussion. But for an older patient, plan to auscultate the lung bases first, to detect common problems before the patient gets fatigued. At each point, note the intensity, pitch, duration, and quality of the breath sounds. Posteriorly, you should expect to hear bronchovesicular sounds over the main bronchi. These sounds have a moderate pitch and intensity. They're heard equally as long on inspiration and expiration. You should hear vesicular sounds over most of the lung fields. These low-pitched, soft-intensity sounds are heard longer on inspiration than on expiration.
Great, now raise your arms above your head and keep breathing slowly and deeply.
Laterally, you should hear vesicular sounds, which are especially prominent in the middle right lobe and left lingula in the axilla.
Great, you can put your arms down and relax, but keep breathing deeply.
Anteriorly, you should hear bronchial sounds over the trachea. These high-pitched sounds are louder and may be heard slightly longer on expiration than on inspiration. You should also hear bronchovesicular sounds over the main bronchi and vesicular sounds over the rest of the lung fields. In a young child, you're apt to hear bronchovesicular sounds throughout the lung fields because the thin chest wall transmits sounds better. However, vesicular sounds may still be more prominent. As you auscultate, listen for adventitious or abnormal breath sounds. For example, you may hear crackles during inspiration. These discontinuous sounds may be high-pitched fine crackles. Or they may be loud, bubbly, coarse crackles. Bronchi are continuous, deep, sonorous rumblings. Wheezes are continuous, sibilant, or musical noises, usually heard on inspiration, but sometimes on expiration also. A pleural friction rub is a continuous, dry, grating sound.
Normally now, I'm going to listen to your back and have you say some specific words for me.
Finally, auscultate to detect vocal resonance, in which the spoken voice is transmitted through the lung fields.
Normal voice.
99, 99, 99.
The patient's voice should sound muffled and indistinct, and should be heard best medially. If the patient's voice sounds clearer and louder, he has bronchophony, a sign of lung consolidation.
99, 99, 99.
Good. Now whisper 1, 2, 3 for me, please.
1, 2, 3.
If even whispered words are clear on auscultation, your patient has whispered pectoriloquy, a sign of more severe lung consolidation.
2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1
Normally, you should hear a muffled E sound. But if the patient's E's sound nasal and like A's, he has egophony, another sign of lung consolidation. As you've just seen, inspection, palpation, percussion, and auscultation can tell you a lot about your patient's lungs and thorax. By using these 4 techniques consistently, and by considering their findings along with the health history and diagnostic test results, you can assess your patients fully and accurately.